I think it's always important that we do our land acknowledgements, but also add our own experiences and commitment to the truth and reconciliation process that we all should be engaged in Canada. So while my work is very much dedicated to the liberation of Black people and addressing anti-Black racism in the healthcare system, I'm very conscious that it is not done at the expense of Indigenous communities and Indigenous people. Um, and with that, I kind of was thinking, okay, what should I talk about? It's Black History Month, it's Valentine's Day, it's, Family Day weekend. All kinds of things are happening right now. And I thought instead of just giving a big lecture about, the disparities Black communities are experiencing when it comes to HIV, I would start off by giving you some historical context in keeping with Black History Month. So I'm going to share my slides. I'm going to get very small and not be able to see all of you when I do share my slides. If people have questions, we will have some time at the end for those. So as Amy said, I am a fairly new professor with the Department of Health and Society at the University of Toronto, and also the founder of a new research lab, the Black Health Equity Lab, which focuses on designing and developing health programs and solutions with and for Black communities. Um, One of the things that became very apparent to me, especially as someone who comes from working in community, and I spent 30 years in the healthcare field before coming into academia just a few years ago. And when I started my work, especially as a young social work student, coming out of social work school, my first job was in a very, very newly formed AIDS service organization to provide support to continental African people living with HIV. And it was before we had medication, it was before we had adequate treatment. And as a social worker who was the sole employee of this organization, my entire caseload would pass every year. I would lose my entire caseload. And then when we finally did get the first medication, AZT, my clients weren't able to access it. And still, I was losing my caseload, even though there was a treatment. And I saw how long it took for the Black community to actually become a critical thought in the HIV sector and field and within the HIV movement. And so I had to really think about, where does that come from? It doesn't just show up out of nowhere. And so I started thinking about some historical reasons why we have such disparities in health outcomes, particularly when we look at HIV for Black communities. So I can't see your hands, but I'm just wondering how many of you um, have heard of this name, Robert Sutherland. If you have, you can say yes. I see one thumb, a yellow floating thumb. Okay. Not many people have really heard about Robert Sutherland, but he's an important figure in Black history. He was born in 1830, which means he was an enslaved African in Canada because slavery doesn't end until 1835 in this space. And he dies in 1878. One point of distinction for Robert Sutherland is that he's the first Black university student in Canada and the first Black lawyer. Now, this is important because to be coming out of enslavement and being able to compete academically when for almost 400 years Black people were not allowed to be educated in Canada is pretty much a big accomplishment to be the first Black university student and the first Black lawyer. He goes to Queen's University for undergrad and Osgoode Hall for law school. So pretty prominent schools at that time, still. But what's notable about Robert Sutherland is that when he died in 1878, He left his entire estate to Queen's University. He is a very wealthy man at this point in his life, being the first Black lawyer. He has no heirs. He has no children, no wife, and so or partner. And he leaves his entire estate to Queen's University. What a lot of us don't know is that Queen's University had actually gone bankrupt and was about to be annexed, taken over by the University of Toronto. And his endowment, what he left that school, is what allows us to have Queen's University today. He leaves the university so much money that it is able to take itself out of debt and operate for many years, meaning pay all staff, cover all expenses, maintain property, buildings, etc., for many years. And we don't know anything about Robert Sutherland. There isn't a building named after him. There isn't a room named after him. Right? Very little acknowledgement of an enormous contribution to Canada. What we also don't realize at this time, most of our universities are actually funded by slave wealth. Dalhousie University is named after Lord Dalhousie, who is the biggest slave trader at the time. And that's where his wealth comes from, and that's the money that is what makes up the foundation of Dalhousie University. McGill University is named after James McGill, whose claim to fame is that he owned the most number of slaves, Black and Indigenous slaves, in Canada. And this is where his wealth comes from. And we name these schools after these people, but no recognition of Robert Sutherland's contribution. The other thing that is important for you to note is that at this time period, just after slavery, the Black community is determined to succeed, and we believe education is the way to our success. So we see our first Black physician show up by Dr. Anderson Ruffin in 1861. And our first female Black physician is Dr. Sophia Bethina Jones in 1885. Emily Stowe is the first woman to become a physician in Canada in 1880. There's only 5 years difference between her and someone who is one generation out of slavery in terms of Dr. Sophia Bethina Jones. And at this time period, it is very common to see many Black people in schools of higher education, in advanced career programs. This is Queen's University Medical School graduates. It was not uncommon to see Black people in these graduating classes because we understand, right, the importance of education and how it's going to advance our community. Canada is not happy with the success of formerly enslaved African people. And two things happen. In 1910, a report comes out, and this is called the Flexner Report, a very important document for us, especially those of us that work in the healthcare field. Abraham Flexner was an educational specialist in the US. He was hired by the American Medical Association to develop the standards of practice for medical schools across Canada and the US. He set these standards so high, particularly financial standards, that Black medical schools and Black programs for healthcare providers were not able to be successful. And most of them were closed in Canada and in the US, where segregation was so prominent. Only 3 medical schools were actually able to survive this Flexner report. In his report, he states that Black students should be trained in hygiene rather than surgery and were best employed as sanitarians who could protect white people from common diseases such as tuberculosis. Quote, he's saying that Black people were best suited for cleaning, not as healthcare providers, definitely not as physicians. And he goes on to further say in this report that medical schools are wasting small amounts of money, small sums annually, and sending out undisciplined men of poor character, whose lack of real training is covered up by these medical degrees. This report is quite racist and very specific about the role that Black people should play in the healthcare field and led to the closure of organizations and schools and institutions that educated Black healthcare providers and called for the expulsion of Black people from all medical schools, in particular, across Canada and the US. This is followed by an order in Parliament by our Prime Minister at that time, Sir Wilfrid Laurier, who then prohibits the migration of Black people to Canada. The order, but this is a small sample of the order. The document is quite a racist one. And he says that the Negro race is a race which is deemed unsuitable to the climate and requirements of Canada. And this is where we fortify the longest militarized border between two countries, the Canada-US border at this time, because of the fear of now people who are free, Black people who are no longer enslaved in the US. The fear is that they would cross in great numbers into Canada. And so he bans the migration of Black people to the country. He then goes on to spend an enormous amount of money promoting this idea that Black people are not suitable, right, for our institutions and the promotion of Black people being expelled from institutions. What follows is Queen's University, despite being saved by Robert Sutherland, the only reason why it still exists is an endowment left by a former enslaved African man. They ban all Black students and expel all Black students from the university, and this sets off a ripple effect across the country. Um, One of the medical students of the 15 that were enrolled at Queen's University was Ethelbert Bartholomew, and he was expelled from the school. And these people were not allowed to go to other programs or take other university degrees. They were expelled from universities across the country. And he took the only job he was able to take at that time or be offered at that time, which was as a railway porter. So you go from almost finishing medical school to becoming a railway porter so that you can take care of your family. The last Black student through this ban at Queen's University was 1918. Queens maintained this ban as policy until 2018, 100 years. In 2023, an apology was issued and an acknowledgement of their role in terms of creating a climate and culture where Black people were unable to get medical degrees and work in the healthcare field in great numbers in Canada. And to give you some context, the tall man standing next to the dean, Jane Philpott, who was the dean of the medical school at Queen's University at the time of this apology in 2023, is Dr. Lanville Daly. He's the first Black student readmitted into Queen's after this ban. And Dr. Daly, to give you, this is recent history, was a physician, our referring physician at Women's Health and Women's Hands when I was the executive director. He's the referring obstetrician and one of the only obstetricians who would deliver our babies, particularly those that were high risk and very much including those of our clients who were living with HIV. So we owe Dr. Daly a great debt. And he's an important part of our history in HIV, but he's also part of this long legacy that many of us don't know about. I went to university in 1985, and I am the first generation of Black people in Canada who were able to enter university where there wasn't an active ban or policy that we could choose any university in Canada to attend as a Black student. So this is very current history. And to think that Queens only removed that policy in 2018 is pretty shocking. Now, I tell you this long story during Black History Month because it's very important that you understand the context in which we are still struggling as Black people to receive appropriate care in our healthcare system and also to understand why there is a lack of Black healthcare providers. It's estimated that 100-year ban for Queen's University impacted a potential 2 to 3,000 physicians Black physicians who could have graduated from that school. And that's just one school with a ban. Many of the schools across the country had similar policies in place. So that removes an enormous amount of healthcare providers and the legacy of what we could have accomplished or achieved within the healthcare system as a Black community. So when Wangari Thoreau and I started our work in HIV in the 90s and realized that there was no researchers who were doing research, particularly on Black women living with HIV. And even though we were seeing exponential growth of members of our community living with HIV, and no research to help guide us in terms of what were the issues we should be addressing, how should we be providing this service effectively, we decided to take matters in our own hands, and we conducted the first study on Black women in Canada living with HIV. I won't talk to you about the challenges of getting funded for that research, and also getting that research published was also a challenge. And so that first study is published in 2002. It's interesting to be a part of the history um, and legacy of HIV and understand that the challenges that we have as Black people trying to navigate the system and as Black women trying to navigate the system are long-standing but still ever present with us. So I wanted to give you some historical context so that you understand the history, or a portion of the history of why we have the disparities that we have today. When Wangari and I published that study in 2002, we thought it was the beginning of addressing HIV and Black women, and we really believed it was the beginning of the decline of the rates. What we didn't realize is that we would not have the tools, the resources, the support, the allies, all of the things that we needed to actually stop what we were identifying in 2002 from happening. And you can see that once we get to 2011, 2015, these are the rates of HIV new diagnosis for Black women across the province of Ontario, which is where I am located. Um, Women's Health and Women's Hands Community Health Center, which we were writing about, is located in Toronto Central. 70% of all new HIV infections experienced by women at this time were attributed to Black women. And you could see the rates across every health unit in the province for Black women. We now reach 2020, and nationally, the rates are still growing. We make up 25% of all new HIV infections for the Black community as a whole nationally. But when we look at women in Ontario, 44.4% of all new diagnosis could be attributed to Black women. So what we're seeing from 2002 up to present day is no decline in the rates of HIV for Black women. And we have to go back to those historical parameters that were set for us in our healthcare system, and no alarms going off, and no resources being put to address this issue. Just to give you some more context on how this problem gets exacerbated. And I'm supposed to be talking to you about Black HIV equity, but I'm telling you about the inequities so that you could think about how to address and become equitable in terms of how we are going to approach this situation collectively. If we look at the city of Toronto, the darker the brown, those are the neighborhoods with the highest percentage of Black people. The red circle represents approximately 90% of all HIV services in the city. So you can see where the HIV services are located versus where we are living as Black people. So even just within the city of Toronto, traveling as Black people to get the services that we require is an enormous feat. If we look at our transportation system, this is our subway system. The white dots represent the end of the subway lines. The subway lines, if I was to put this on top of that map of where Black people live and where HIV services are, every subway ending ends before the Black community, neighborhoods where Black communities are predominantly living. So even just basic transportation, right, and the routes that we have to take to get to those HIV services that are in the downtown core create basic barriers for our community. If I look at the CHIWOS data, which we're just now looking at the data specifically to Black women, um, we can see disparities in terms of Black women living with HIV having access to a regular family doctor. We have the highest possibility of not having a family doctor. A lot of this is due to where we have to travel to get to services. There is a shortage of family doctors, I understand, but it's a combination of not having family doctors from your own racial group or community, as well as where they're located in relationship to where you are. Black communities have the least amount of healthcare services in Toronto, for example. If we look at the time it takes for you to get to your HIV appointments, Black women are most likely to spend the most time traveling, right? 1 to 3 hours one way. Some folks are traveling 3 hours one way to get to the service and 3 hours home. That's 6 hours out of a day. If you don't have paid time off to do that, if you don't have the financial resources to pay for that, you can see how challenging it is to even address your health condition and your health issues. The cost to attend appointments. Black women are also most likely to spend the most, whether it's transportation, whether it's childcare, whether it's all the things that are required for you to attend your appointment. Black women are more likely to spend the most money, according to the CHIWOS data. So, I've given you some issues to think about just in terms of what creates HIV inequity and differing experiences for Black women in particular. One of the things that my lab is very, very keen on is to not just conduct research, which is going to tell you about all of the problems and challenges that we have as Black people and as Black community members in addressing anti-Black racism. One of the key things that we want to focus on are solutions and creating solutions. Um, the IA Circle of Care is the first study from coming from the Black Health Equity Lab, and it's an implementation science project where we were working with a community health center to design and develop the first HIV program for Black community members and their families. And we're very excited about this program. It's titled IA Circle of Care. It's located in Taibu Community Health Center, which is in the Scarborough community. Taibu is a community health center that is already designed specifically to serve Black people. So we thought it was very appropriate that the first clinic that is designed specifically for Black community members living with HIV and their families will be housed in an organization that was already providing health services for Black people. You can see a picture of the service providers within the clinic. Within the past year, we have our full caseload. We use an intensive case management model where the cases are small in nature, no more than 20 or 30 clients at a time and their family members. And they get complete, incredible wraparound care for a very intense period so that we can address all of the social determinants of health that are impacting, that we can actually get viral loads reduce very quickly, and to also get people at a state um, of wellness so that the issue is no longer the focus on HIV. It's all the other issues that they have to deal with in their lives that are creating a scenario where someone may not be able to manage their HIV in the ways that we would want them to. Before we go into some questions, what I wanted to leave you with are some advocacy tools that I think are very crucial if you're truly doing anti-racist work and if you're doing anti-racist work that is directed at supporting the Black community. One of the things that has created some of the scenarios that I've talked about is the fact that we've often been left to do this work on our own with limited resources, and that is not effective. When Wangari and I conducted the first study on Black women and HIV, that came out of necessity. We needed to have answers. We needed to know how to provide services more effectively. We needed to know what our clients were dealing with. And we approached many researchers in many universities at that time who were in the HIV research world to do the study. We were not researchers at that time, and nobody came forward to assist us. And so we had to figure it out on our own. And that's how I became a researcher, to be honest. Um, I later went back to school to get all the credentials, but the research initially came out of necessity for not having supports in the system to help us. So some of the advocacy tools, things that we need to put in place that are crucial for us to start really addressing the disparities I talked about in terms of Black women and HIV. Racial and cultural concordance. So having service providers who look, sound like you, understand what your issues are, understand who you understand what your experiences are, and understand what your community's experiences are crucial. And we can't shy away from that. There's enough research that tells us, even in terms of Black healthcare providers, nurse practitioners, and physicians, that Black people do much better, survive much better when that provider is from our community. So that is something we have to address, right? How many Black HIV specialists exist? How many Black programs exist specifically providing primary health care for Black people, for example? The I Circle of Care is the first in the country. It won't be the last, but it's the first. We need more. Black-led research and programs. So research that includes Black people is not Black-led research. Black-led research is research that is developed by Black researchers with Black community members who eventually use that research that comes from a strong place of knowing and understanding community to design and develop programs with and for us. Black-led research also interprets our experience differently than research that includes us. And so I emphasize the need for more research dollars to be dedicated to Black-led research. For a community that has some of the highest rates of HIV, if we look at how much research dollars has gone to this community, the Black community specifically, that is a disparity in and of itself. Even though we study disparities, the disparity is actually the limited amount of research dollars that is actually going to this community. We need to focus on interventions that address Black social determinants of health. So understanding what are some of the barriers to us effectively addressing HIV in the Black community is very much tied to the social determinants of health, all kinds of other things. I gave you a few to look at, just in terms of where services are located uh, that serve Black communities, transportation, right? We can look at housing, which is such a big issue right now for many communities. But how do we involve these and include these interventions and work with other sectors to address those social determinants of health that are specifically impacting Black people and Black people living with HIV? We have to look at interventions that address HIV stigma and racial stigma, the intersection of the two things. HIV stigma is very real. It is one of, I think, the strongest barriers to people accessing services effectively. And one of the things that we learned at the IA Circle of Care is how to become an HIV stigma-free zone or service. What were the things that needed to be put in place? Working with an advisory committee of people living with HIV throughout the entire research project was crucial for us to understand how to design the service, what the reception area looked like, what intake looked like, um, all of the things that were barriers that were related to stigma that would stop people from coming to use the service. One of the things that I often hear from white service providers is, oh, my Black clients won't go to a service provider who's Black. They don't trust them. And, the question I ask them is, well, how are you fanning that mistrust? What trust are you, right, supporting your client to develop? How are you working with Black providers and Black organizations so that you're not fanning that mistrust in the white dominant organization that a Black person is receiving services from? And I hear this all the time. And what I found very interesting with the IA Circle of Care, all of the providers are Black, and it has never impacted people getting service. I've never heard them afraid to go for service. On Friday, we had an event, community event, um, post year one of the full program up and running. And the number of Black clients who stood up in public for the first time to talk about their HIV diagnosis and to talk about the care that they received from someone who looked like them and sounded like them and understood them was absolutely incredible. We had our first baby who was born in the program, and the mom stood up with the baby and to let us all know that the baby is now named after the Aya program. Those are testimonies that absolutely tell us that it's important for us to have Black-led programs and services and service providers, and that our white colleagues and colleagues of other racialized groups also have to promote, right, the effectiveness of racial and cultural concordance in services to Black communities. We have to look at treatment as prevention and look at ways that we can increase access and use of PrEP, for example, use of PEP. How do we increase access to all technologies that we should be able to access as Black people? Um, we're seeing very, very low uptake and information provided, particularly around PrEP. And how do we change that? And how do we provide resources so that that can happen? We have to be very diligent to address anti-Black racism in our HIV policy, in HIV research, and in HIV service delivery. And we have to stop putting our head in the sand and pretending that it's not present, that how policies are being developed, how we're being defined still as Black people, how resources are allocated, um, definitely needs to be addressed in terms of the anti-Black racism that we're still experiencing in the HIV policy realm, research realm, and service delivery realm. And then applying principles of health equity to HIV resource allocation. So, if we go back to the tenets of our universal health care, the Lalonde report, it's very clear in that report. Communities with the highest risk of health issue should get the most resources. Because very simple. That's what universal health care means, and access to universal health care. We are not applying that in the HIV realm, right? The communities with the highest risk should get the most resources. So until we start seeing that with both Indigenous and Black communities, we will continue to have the disparities that you're seeing today. I'm going to stop here. If you want to learn more about our research, if you want to learn more about the Black Health Equity Lab, we have a website. And so you can reach out to us and learn about our research and work. These are the students of the Black Health Equity Lab. One of the key ideas of this lab is to also provide Black students the opportunity to engage in research with and for their communities. and to start creating the next generation of HIV researchers that we need to continue doing this work. So I'm going to stop here and open the floor up for questions.